This is a very important question about the best practices for the community setting for the TAG agent. Now that it's been out for 5 or 6 years, I'm proud to say that essentially what we reported on and published, what's in the FDA package insert, is what I really do in my clinical practice, and I'd like to review that. Number one, the most important thing is there needs to be a multidisciplinary team for all BPDCN patients. So whether you're getting TAG or a clinical trial or a combination, because it's such a rare disease and it's such a complex one involving the skin, the bone marrow, the lymph nodes, the central nervous system in many of the patients, it's a bit rare. It's not as common as, say, AML or ALL for the PharmDs, for the nurses, for the patient, the family. So I think quite a bit of education has to go into it. The second aspect of the drug is that it is given IV. It's planned for up to 5 doses, but there is tripwires on each day of the dosing. So you have to look at the albumin, the fluid status, eyes and nose, daily weight, liver tests, kidney function. This is very important. This is how I personally did it during the clinical trial. This is how I do it in the standard of care setting. So it's good to know and to plan around weekends, holidays, etc. So with your team, who's on call, etc. Number next is it's very important to plan out if there are toxicities, how will they be managed? For example, we found that high-dose steroids, if given early in the capillary leak syndrome, if it's actually developing, can really be life-saving. And then lastly, I would say with the TAG agent, what's very nice is that you can see responses very quickly. So this is with almost a lot of these BPDCN therapies. I think it's a very highly steroid, chemo, CD123 responsive disease. So with the TAG and with the clinical trial agent, IMGN, you can see skin lesions resolve very quickly. I'm talking about in a matter of days or weeks, which is very gratifying for the patient, the caregiver, and for us. But to remind people that BPDCN is often deeper than the skin, so keep looking at the bone marrow, PET CT scan, and other imaging for the lymph nodes. So remember that BPDCN is a multi-compartment disease, and that these treatments can in fact lead to remission in those compartments, but we have to check them.